All right, so we're to our first sales call of the summer. This is entitled BFR and how it helped increase my revenue. I almost want to retitle it to Finding the Gap because what we're going to do today is find the gap that you have, you as in plural, your patients have, and how you can better serve them. So that's how we're going to focus. I did that through something called BFR, so blood flow restriction therapy. So I'm not trying to sell you on BFR. I am trying to like expand your brain so that you can actually think of different areas where you can utilize some kind of add-on. Maybe in this case, it was investing in something new, so that I could increase that revenue. Amelia, we're so glad you're here. So BFR, blood flow restriction therapy. It actually dates back all the way, the research started at like 1940s. And so what they were seeing were veterans, or I should say active soldiers, that had some kind of injury that impaired specifically their limbs. And they were trying to strengthen those limbs for prosthetics. Um, Even just the soldiers, some of the stuff I looked up recently was that they did a tourniquet on those limbs. And what they noticed was that the muscle mass of those limbs was maintained far greater than those that were not tourniquet. So even if they were just, for whatever reason, like just for safety reasons, and I also have so many questions on this too, because I'm like, well, how long did y'all tourniquet them? What was the end goal? Like, did you just leave them tourniquet, in a tourniquet? I'm not sure. But so what they saw very quickly was that they were not reducing or losing that muscle mass as quickly. So the theory behind this, or the science behind why this works, is that you have the two types of muscle fibers, right? Like we know this as PTs, but other people may not. So you've got your type 1, you've got your type 2. Your type 1 I'm using right now, right? Like I'm standing, it's my endurance, I'm using this at all times. The type 2 fibers are strength and power. They normally engage at very high loads. That is why you see these people maxing out. You see these sprinters just keep doing those reps at high, high, high intensity, right? So the way that BFR works is it actually tricks it doesn't, I don't even like the word trick. It actually puts your body in a lower oxygen environment. So hypoxic, slightly hypoxic, which is where we get when we're activating fast twitch fibers. So think maxing out, think sprinting every time. So while you do not have to lift that heavy a load, it actually gets to fast twitch fibers. So normally you might have to squat, 250, 280 pounds or whoever you are. Let's use 100 as your one rep max for purposes of math and me doing this. So if 100 pounds is your one rep squat max, you would get these same benefits and gains by squatting using a BFR occlusion cuff with 20 pounds, which that's pretty crazy, right? Um, yeah, and so that's why this is so exciting because as providers, we think about those patients who can't load. Maybe they're post-surgical, maybe they've just had an injury, but we still want them really strong. So this is a way to force the blood and metabolic byproducts to pool inside that muscle by using the occlusion therapy. So it restricts venous return, but then obviously arterial flow is still going. So when you use the real ones, like the medical grade, you're wearing that cuff at the top of the limb, whether that's arm or leg. It's checking the occlusion pressure. And then the system I have where I can change it. I can do, 60, 80%, depending on what my goals are and the patient's tolerance, because it's pretty intense. So as anytime you're experimenting, right, you're going to do it on yourself. So of course, that was like the first thing we did here in the clinic was we put those on and we said, okay, how does this feel? Is it because people will call it a cheat code, but it doesn't feel like a cheat code when you're in the middle of lifting it, right? It's very intense. So that also has been really good mentally for a lot of my providers who are like, I want to feel like I'm working out. I want to work hard. And so they can get in the clinic and really work out. So they're building strength. They're with a 20 to 30% of their one rep max versus 70 to 80%, which is where you would, modify that for. In our older patients, they can lift harder. And it's just, there's a ton of evidence around this, which is what's really exciting because there's a lot of these things, even cupping and dry needling. I know that they work and they work well, and I do it every day, all day.
Mhm.
But the data, we don't have as much data behind it. With the BFR, we have really strong data. So the what I want y'all to remember, and hopefully you can see a little bit of this. So it's high load. Anybody watching this, high load,
Mhm.
you're getting type 2 fibers, type 2 activation, and then you're getting strength gain. So you're increasing your strength. But then with BFR, you get the same thing, but you are low load. So one of my favorite stories, so you're getting the exact same thing. You're still getting type 2. Can we see it at all?
Yeah,
It's
can
so
you just shift
blurry.
it a little to your left, Kel? Yeah, there you
Yeah.
go. Perfect.
So we're getting type 2. So same thing, but way lower load, right? So super cool stuff. One of my favorite stories, and one of the reasons we really got this going here at Dripping Location, was that we had a very high performing athlete, like elite athlete. I wouldn't say elite. She is still just like high school, but still very high level, going to nationals, playing volleyball, comes in, and I detected a stress fracture in her foot. So obviously she can't load anymore, right? Well, we're right in the middle of seasons. We're trying to qualify for nationals. Immediately after that, trying out for all of these teams, these high-level volleyball teams, plus the high school teams. So what happens when we put some money in a boot? Immediately,
Mhm.
right? Like immediately we lose that muscle, but we have to protect the joint or the bone rather in this case. So how do we balance that, right? Like that, and that was her big fear was I've worked all season to get really strong and to really be able to nail this, but I'm going to lose all of these gains. Well, so we got the BFR cuffs. We immediately started. There's some school of thoughts use a very specific protocol. I don't know, Amelia, do you use the specific 30, 15, 15, 15? You can just nod if you do.
I don't necessarily follow that. It depends on which age group I'm working with, and then also the athlete level.
Yeah.
With the younger ones, they tolerate it a little bit better, but the older ones usually actually prefer the like 1 to 3
Yeah.
comparison.
Yeah. And so that's kind of the what they've said. They've studied and said the 30, 15, 15, 15, Owens Recovery Science, which is like the big leader in the United States for all of these. That's kind of what where they've pushed it, is to do that protocol. But so the end of the story is that we got her through that protection phase, got her back on the court, didn't miss a beat. They qualified for nationals. She came in no pain. She actually had pain in the other foot yesterday. And so that's a whole patient, that population and type of injury that normally we would not be able to service, but we are. Like, I mean, I could give her a few things, but she's not going to pay cash and come in for that while she's recovering, right? And so that's kind of why I want to call this find the gap, right? I want you to be able to see like or start thinking about what are these things that I can use that can reach a population that would otherwise maybe not be coming in at all. And for me, that was BFR. And so those are people, that's like increased revenue that I would normally just not get, right? So that's a whole new patient population there. But the other thing is just adding value to those patients, especially when you're cash pay, to be able to add these things, these, different types of tech and up and coming, they want to know that you are the best of the best. Like you're bringing them the top level evidence and treatment because that's what they're paying for, really. So they're paying for that individual care. And so adding that value to existing patients, but also just increasing exposure. A lot of our providers are not in a clinic where people see them. I am actually in a clinic where people can see what I'm doing to my patients. They can see all of that. And so that is something that people go, oh, what is that? Tell me more about that. And they're hearing stories of someone coming in today because of the story I just told you. That's how I got them, and that's how they came in. But yes, Amelia, do you have a question? Did you raise your hand?
So yeah. Sorry, I'm trying to multitask here.
That's awesome.
Um,
That's great.
so my question is, I have a couple of patients that I definitely sell the kiddo on because obviously their goal is to, be the best, player on their team type of thing.
Yeah.
And definitely use their ability. But how do you handle parents' hypothesization on growth stunting that is simulated in like gymnastics and everything, which is why they're 5 foot nothing when they start really young and they have that much muscle mass gain? The growth stunt factor really deters the parents from BFR on their kids.
I've actually not had any of that pushback, but I like that question. I also think we're trying to do, from what I have read, it's been approved for 12 and up, which is basically where I'm kind of living. Are you dealing with that more with like a younger population?
She she's 11,
Yeah,
and I really don't like to use it on anyone younger than that anyways,
yeah.
but I've
Mhm.
also had a 17-year-old parent as well have the same like question on that.
I mean, with the 17-year-old, I would say you've probably reached puberty, so we know that you can already maintain muscle mass and like bulk, bulk up. Because when you don't have the right hormones, right, you're not able to actually get the like
Yeah.
huge gains in muscle mass. And so if you're, I would say, well, are you also opposed to them lifting weights? Like that's how I would frame that. Like I just want to know where their mindset is. Because if they're also scared about lifting weights, like you're not going to create an environment for so long, like a high level gymnast. You're not stressing the body that much. You're stressing it twice a week for 30 minutes, you know? So I think it's the dosage, right? Is it medicinal or like what's the difference between medicine and poison is the dose. And so that's how I would frame it too, is we're stressing the body just enough. And then of course I would tell them to their ask their pediatrician if they were really worried about it. I haven't really run across it, but I've also been careful to not do that in kids younger. But I've had patients there's one right now, she just turned 10 and she had BFR post I guess I think it might have been a tib fib fracture. And they just raved about it, thought it was so great. It wasn't me who did it, but I thought, oh, that's interesting because I think that kiddo was 8 then.
Okay.
Yeah. So it's kind of answers the question. That doesn't really answer the
Yeah,
question. That's how I would approach it, I guess, is
okay.
what I would say. Yeah. Yeah.
Okay. Thank you.
Brenda, did you have a question?
Yeah, I was wondering, which BFR unit are you using? Are you using like the $5,000 individual one that's like medical grade? Um, I I use the smart cuffs. I don't know if there's like something that's better than that, other than the one that's a little bit more medical grade. Just was curious as to what everybody else is using.
Yeah, actually also using smart cuffs. I didn't, but another provider in this location researched it, and they felt like that was one of the best ones as far as like kind of skirting that line of like, are we, because there's Owens Recovery, which I mean you're talking about 5 to 8 grand, I believe. And that's like where they started. But it's like with anything, right? It starts out like completely like left just to medical. Remember when the elliptical was only in the physical therapy clinic, right? And now it's like in your grandma's garage, like it's everywhere. So it's kind of like that. And cupping, like I feel like you see people just getting cupping sets now, just left and right. But yeah, so I do feel like smart cuffs is because it does calculate the occlusion pressure and you can do it each time, right? Like you can save it or you can recalculate it. And I'm manually changing it like to what I want. I feel really confident in that, like that it is a higher like grade or product. So has been your experience with the smart cuffs? Are you using them a lot?
Yeah, I use them a lot for like post-op typically.
Yeah,
Especially when we can't like really load them up or we have to be a little bit more protective, right? So
right.
it's just like, as you said before, it's just like a nice thing to have, and people feel like you're adding value to their experience, and it you can sell like um, bigger plans of care because all of a sudden now they want other things addressed that they may not be able to get at like other clinics. So,
Right.
yeah.
Yeah. Yeah, and I think that's the key, right? Which is why I have some of these numbers written down so you can see some of them. So the BFR
That's
sessions, like the standalone 30-minute sessions, we charge $89.99 for those. So I looked back and we've had these for about 6 weeks. And so we've made almost $450 for those just standalone sessions. But then I went through and we added in, and that was with just one provider using them. So now we've got two providers using them. We added in the BFR to different sessions who they already had like a full hour session, and we added that in. And so that was 10 visits. So that got us to oh,
Can
I'm
you
gonna
pull
show
that
us
forward
that.
again, Kelly? It
I
looked
wish it
great
was
when you
that.
pulled it
So it was
forward.
about $1,600. $1,600 is what we got for that. The cost was $800 plus I have two different sets. So we're at $1,600 there. So we're already in the positive $500. So I asked Chad, I said, okay, my 6 week revenue for that is $2,100. If I projected that out for the whole year, that would be it's projected if it just stays the same. So if I don't even increase it, which I will because I'll start advertising it more. That net from BFR alone is like 16,500. So that's just, like I said, this is just finding the gap. So that's patients that I maybe otherwise would not have converted or wouldn't have come in, or it's adding in extra services to an already established patient. And then you're only paying for them one time, hopefully. So then that puts it at year two is over $18,000 of projected revenue for using those cuffs. But I really think we could increase that also. Yes, Brandon, do you have a question?
Yeah, I think this is all great. I'm curious, if I may ask, what are your rates for a single session versus the half an hour session? And then how many
So,
patients are you typically seeing in a day?
for BFR or just me in general?
Yeah, you in general, or you and your the people that work with you. How
I
many
see anywhere from 8 to 10 patients a day right now because I'm working 4 days right now. And then the other provider, she's on medical leave, but she was at about five patients a day, anywhere from 10 to 15 a week. Um, so our rates, we never start out with BFR alone. Like they're going to do an eval first because I also think that like to Amelia's point, like, let's really look at the whole patient and talk about the concerns and not just slap these on. So they're always starting with an eval at 194 is what I charge for eval right now. And then they'll do, if they're just doing 30 minutes, it's $89. Now, at 89.99. Those rates, because I looked at it when I had chat run an analysis, I was like, oh, well, that's not very many. And then I was like, you know what I saw happening was people coming in for BFR, but then they see what you have to offer, right? And so it's like, I don't want to just do BFR. I want to also do manual therapy. And then you're like, okay, we're doing a whole kind of what you said, Brandon, like we're really beefing up what we can offer. We're really standing apart from other clinics in the area. And so then there's your buy-in, right? Like, and that's what's been really great for us. So the half visit's $89.99, but the eval's $194 compared to our follow-up visits are 162. So if you are doing that, you are making more money, just a little bit more for doing like if you had two BFR in 1 hour versus a follow-up in 1 hour, if that makes sense. You're at 162 versus like almost 180. Yes, ma'am. Dr. Shania Grody.
So my question is, let's say the reverse happens where they come to you for an eval and you think they're an excellent candidate for BFR, like right off
Mhm.
the bat. So then would you run through a normal course of care? Or would you just include that as like an adjunct? And would you charge extra as like an add-on?
Ooh, good question. Um, Right now, I do not charge anything extra for add-ons. So if you come
Okay.
in for an eval, and I think that it's appropriate for you to have dry needling and then cupping,
Hmm.
that you get dry needling and cupping. If you come in for just dry needling, that's another thing.
Hmm.
If you come in, to Brandon's point, post-surgically, and I think, oh man, this BFR would be really great for you, then you're just going to get BFR lumped into your visit. What I am seeing and may need to troubleshoot soon is that when you're doing the BFR plus the manual, it does tend to be like an hour 15 visit is what I'm running into. And so wondering that that might be something that I'm going to need to accommodate for very soon. Um, such as life, right? Like we need to accommodate for it. Like, wait, it already happened, obviously.
Oh,
Yes,
that's great.
Brandon.
That's great. I was curious. Thank you.
What you got, Brandon?
Oh, sorry. Last and quick
Yeah,
question.
no, this is what it's
Um,
all about. This is great.
yeah, so for those evals that you're doing where I don't know how your evals look because it seems like you're a little bit more sports based, right? I'm assuming the eval's an hour, but it seems like there's a lot to evaluate on the physical therapy side of things, but then on the training or performance side of things. Are you able to do all of that and also maybe get some treatment in, or
Yes, but after
is
talking
there?
to you and Shania a little bit more, I've actually done a little bit less treatment in the eval because, like, you need to come back for that. That's the hook, right?
Yeah.
So I've really slowed. Definitely, I can get that done in an hour, but I've also been doing this for 20 years at this point. So I'm old, and so I can, it gives you a little bit of one good thing. Now, they're not all good things. One good thing is I can talk to a patient and probably do things a little bit faster. And so I leverage that. And then I really try to pick the lane I'm going to go in, like pick one thing or pick two things that we're going to focus on that day. And so maybe that is just force plate testing, or maybe I'm not trying to think if I've done BFR on a first visit. And I maybe if they had a previous relationship with me, but if it's someone just walking in, it's more education of like, this is what I think would be beneficial for next time. And so with that first patient, you're still, especially in cash, I mean, everybody's in sales, whether they want to be or not, right? But especially in cash pay, is I'm really looking at like the one thing that brought them in that like I'm peeling back that story of like you can't sit in that car to see your grandkids because you're stiff when you wake up. So I'm going to try to address that even though in my brain I'm like, oh gosh, we need this mobility. We could do some dry needling. We could do where I think 5 years ago I threw all of that at them and it probably overwhelmed them. Their brains and their physical symptoms. And so now I've kind of peeled back with that, but I try to see what's the most important thing to that athlete. Is it their vertical? Is it that their balance is poor? Is their parent coming in saying that they're walking funny all of a sudden? And I try to just pick the one thing for that day and then sell them on what they're going to get from who they're going to become on the other side.
Does that really help with your efficiency?
Yeah, for sure, because I can't see, even though like when I say 8 to 10 patients in a traditional clinic, that's like not busy, but it feels very busy in this environment because you're giving so much to
Hmm.
each one of those, you know? So yes, so picking the one thing that's most important to them, I feel like they feel more heard and it keeps me on track for the day. What you got, Amelia?
So how are you handling your patients with blood pressure issues? Originally it was a contraindication, now it's a precaution. So um, I use the H plus cuffs personally. I originally had the smart cuffs, but I actually would get like myself would get frustrated with how long it would take to calibrate. So I just do it myself and do the math in my head, and I can just set them up a lot quicker. And you can do less inclusion for it since it's now a precaution. But if anyone does the research on it, and then also if they have a lot of like other medical issues, are you actually still doing it on them?
I
Or are
probably
you
wouldn't in this setting. I probably would not, but I've not run across it where anybody is medically complex. But definitely that would be something where I'm going down to like 50% occlusion or something super low. Or I might, if it were me, I might have them clear it with their physician before just to have another set of eyes on it. Um, but with this patient population, you're dealing with like 14 to 16-year-olds constantly. And so they're young and spry, and
right,
healthy,
but
but
more of like the older population that's had like a hip replacement or a knee replacement or something like that, but they also have blood pressure issues. Are you still even considering it on them? Because
I don't know yet. I'll have to wait and see when I get there. I've got a hip replacement right now, but he's like 42.
okay, gotcha.
So yeah, so it's just very different. I feel like when they're coming for like there is a patient we're seeing right now that is much older. Yeah, and I would think it's case by case. I think I would be monitoring their blood pressure each visit anyways, before like for a while before I even got there. Have you dealt with that, Brandon? No? Yeah. Yeah. Yeah, I definitely think it's probably case by case for sure. So, like I said, I love that the two providers that hopped on actually have experience with BFR, which is awesome. They probably know way more than me about it. I know Amelia's been doing it a lot longer, and Brandon's probably ahead of me in it. I'm kind of late to the BFR game just because previously it was so expensive to get a hold of. And now it's so much more accessible. So it may be something later on that we're looking at maybe upgrading our systems to something even higher if we start seeing a large number. Like we already had to double our cuffs, like we had to, and then some of the sizes weren't quite right. Like both providers would be needing them, so we went ahead and went up. But like I said, the goal is not necessarily to sell everybody on BFR, even though if you are, I think it's great because there's so much evidence on it, but it's to find the gap. So which patients do you feel like you could really get better outcomes with, or maybe that you're not quite um, accessible to, or what would be the right word? Like attractive to right now. Like maybe they don't think that you are for them. Um, and and what is it that that patient wants? So for me, the who was like an adolescent athlete, and what was they needed to stay strong, right, while they were rehabbing. And the why is because she had to immediately turn around and get ready for tryouts. And then what would it take? So like what's stopping y'all? What it took was to me being able to stomach spending $1,600 that month when it already like was a crazy expensive month in March because I opened a new location. So it's like, great. So now I'm going to spend an extra one. But as you saw when I did the math, we're already net positive $500 6 weeks post, right? So that's my question that I'm posing for y'all. Like what patient population? And then what is it that they need? Why do they need it? And what would it take? That's the questions I want you to answer. So I'd love to put y'all all on the spot just really quick, and maybe one of y'all can come up with a who, and then we can all brainstorm together the rest of that. Do y'all have one? Do you have one, Brandon?
I do. This is for my patients that have chronic pain,
Mm,
more emotionally related than
yeah,
physically related, that have been in the fight, flight, fawn sort of response. Usually they've had some kind of sexual trauma or physical trauma to their body, and they're just, yeah, their protective mechanism is more about tightening the muscles,
yeah,
as opposed to learning how to generate force.
yeah. So what do you think? So you want them to be able to generate force. That's the what, is
Yeah,
that correct? Okay.
yeah,
Because
just
they're
to be able to
always,
like hold up their body.
okay, I love it. And why?
Because the force that they generate on a normal basis is protective rather than like making them just being able to exist,
So reach a higher potential, right?
reach a higher potential. Yeah.
Yeah, yeah. Live out their calling in life. They're not able to do that when yeah, yeah. So reach a higher potential. So is there is there some, because it doesn't necessarily like have to be, I'm just writing down what you said. It doesn't necessarily have to be what like actually buying equipment, right? That you're investing in. What if it's you're investing in you and your brain and how you provide services, which Brandon has already done that. But so what would it take? Like, and like on a higher level, but as well as a practical level, like, is there actually something that you could purchase, that you could teach, a new program. That's where I would challenge you. You don't have to have an answer today. Yeah. I think we each have like this, I think we each have this in us, right? Like that we can think through. Um, And sometimes maybe that's investing in maybe sometimes it's showing up for these calls. Maybe it's investing in a mastermind, which is what I did last year. Um, yes, thank you, Brandon. I didn't even know this existed until Brandon started telling me about this stuff. And maybe it's just equipment, right? Like Amelia said, smart cups were frustrating. I knew I could do more with a better product. I invested in another one, so that would be just my encouragement. Shania, did you have one?
I was just gonna say, yeah, the people who are like getting back to exercise or like apprehensive or are at kind of like ground zero, like I feel like there's such a barrier to entry, even with paid T. Like playing off of Brandon's point, but even just like recreationally, people who not necessarily have chronic pain, but are just like apprehensive to movement because they haven't moved in so long in a meaningful way. So I think this just like lowers the barrier to entry with like that patient population too and takes the scare factor out of it. Like we're only going to work at this percentage. Like don't worry, it's going to be okay. Might be a little painful during, but like, I just think there's a lot of gap there too, which I could see benefit for me personally in
Yeah.
practice.
Okay, so I cannot wait for y'all to tell me what your who, what, why, and what would it take? I can't wait to hear the answer to those questions because yeah, I do think who are those patients? Maybe it's scared, maybe it's patients that are fearful, fear avoidance. Maybe it's the chronic pain patients. Maybe it's the patients of the parents who are very concerned with, loading or things like that. What you got, Amelia?
Something I usually just like piggyback onto what she just said is the people who are like worried about getting back into things, especially because of the DOMs and everything after the fact. It's you can always say that by creating that hypoxic environment without actually bringing yourself to your max doesn't allow for lactic acid buildup and then that amino acid breakdown. So obviously I'd say it in a lot more like layman's terms, but they don't have the muscle soreness that they would experience by going and trying to max out at the gyms. It usually makes it a lot more attractive to people who end up getting worried about all the either fatigue or muscle soreness and everything after the fact of working out for the first time in a while.
Yeah, that's a really good point. Yeah. And so, and I've even used it for recovery. Like I've had a couple of people come in for just recovery sessions, which normally they wouldn't come in, you know? But there's some research about using it for recovery and just even acute pain. So yeah, there's a lot. And with BFR specifically, I feel like there's a lot to of different populations you can target because it is far reaching. So, well, I will end us just for purposes of time, but thank y'all so, so much for hopping on. And Shania will lead our next sales call in a couple of weeks. Do you know what that will be on, Shania? Sorry, I didn't
I think
prep
it's
you.
gonna be great segue. Yeah, so I think we're gonna talk more into the literature of like dynamic cupping and cupping in general, because there has been so much that has come out since like the beginning of time. So I thought this would be a great adjunct to Kelly's discussion today and just how we can use it in practice from, not just being static. I'm sure you guys have seen Kelly's stories, but we both heavily use the dynamic aspect of cupping, not just static. So we'll delve into that a little bit deeper.
Awesome. Thanks for joining, and we'll send an email out for the next one.
Thank
Bye,
you,
guys.
Kelly.